Hello and welcome to Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. Now, with that being said, in this episode, we discuss premature ejaculation, a problem faced by 30 to 40% of men at some point in their lives. But what defines premature ejaculation, and for that matter, what is considered a normal time to ejaculation? Is it 10 minutes, 5 minutes, 1 minute? What causes premature ejaculation in men? And do all men experience premature ejaculation for the same reasons? And what, if anything, can actually be done to help men increase their time to ejaculation? To answer these questions and many more, we turn to a true expert. Dr. Helen Bernie is a board-certified, fellowship-trained urologist and the director of Sexual and Reproductive Medicine at Indiana University. She is also an assistant professor of urology at the Indiana University School of Medicine, where she teaches medical students. Dr. Bernie completed her residency in urology at the University of Rochester Medical Center and went on to complete a 2-year fellowship in sexual and reproductive medicine at Memorial Sloan Kettering Cancer Center and the New York Presbyterian Weill Cornell Medical College. She's an active member of the Sexual Medicine Society of North America and a member of the American Society for Reproductive Medicine. And now, without further ado, I bring you our conversation with Dr. Helen Bernie about premature ejaculation. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about premature ejaculation. Did you know that about 30 to 40% of men experience some element of premature ejaculation at some point in their lives? Now, for most of these men, it's a little bit embarrassing. It might be a hit to their self-esteem. But for some men, it could be a lot more than that. It could be a pretty devastating experience, which puts them into a vicious cycle where they're avoiding sexual activity and ruining their relationships. Now, with that being said, what is premature ejaculation really? And with that being said, what's normal ejaculation? Is there a normal time for all men in which they should ejaculate? And for those who have been found to have premature ejaculation, what's causing it? And what can they do to increase the time to ejaculation or get to the quote unquote normal time, if there is one? To answer these questions, we are very fortunate to be joined by Dr. Helen Bernie, who is an assistant professor as well as a director of sexual and reproductive medicine at the University of Indiana. Dr. Bernie, welcome to the program.
Thank you so much for having me.
It's our pleasure, and it's an important topic that a lot of guys are interested in. Before we dive into the topic at hand, though, one thing I like to do on the program is to get to know our experts a little bit better. And particularly, what we'd love to know is kind of what inspired you to become a urologist and specifically focus on sexual and reproductive medicine.
So I got exposed to urology when I was in medical school. And of course, just by happenstance, the urologist that I worked with was a sexual and reproductive medicine expert. And I found that I loved urology because it encompassed all genders and all ages of patients, and that you could dramatically improve a patient's quality of life. You know, I was more specifically drawn to sexual health because sexual health is our overall health, right? It's the determinants of patients' quality of life and their sexual intimacy and closeness with their partners. And so I really enjoyed being able to, to be able to educate people on this, to talk comfortably about it and to normalize the process, since so many of us aren't taught anything about sexual health or reproduction.
Right.
And then being able to treat patients, because you can just make a dramatic improvement in their overall quality of life with their partners and everything by restoring that intimacy and sexual health.
No, that's making a big difference for sure. And it's actually funny because a lot of the urologists I speak to, they all say kind of the same thing in terms of they decided to go in the field because of a mentor that really inspired them. It seems like you're in that vein as well. Now,
Definitely.
Jumping to the topic at hand, which is premature ejaculation, I think it's important, first of all, to level the playing field and help the guys understand, is there a normal time to ejaculation that we can compare against, really? Because I would guess that for most men, if there is a normal, it's probably not what they're expecting it to be. What are your thoughts?
Exactly. So there, as you nailed it on the head, there's a wide range of what's called normal time to ejaculate, or in the medical field, we call that the ejaculatory latency time in men. And, if you look at this population data where they took tons of men and looked at them measuring an actual stopwatch timing, they found that the average norm is roughly about 5 to 6 minutes, okay, with a standard deviation of 7 minutes, okay? So there's a huge wide range here that's considered normal. And again, it kind of brings me to, well, what is premature ejaculation then by definition? Well, by definition, it has to be either, there's two types. There's one called lifelong and there's one called acquired. Now, your lifelong premature ejaculation is going to be associated with someone who has poor ejaculatory control, that's also associated with bother and ejaculation that's usually within about 1 minute of the initiation of penetrative intercourse, and that's been present their whole life. The other type is what's called an acquired premature ejaculation, and that as well has to be poor ejaculatory control that's associated with bother to yourself or your partner. And that one's usually timed with about 33 minutes or less with the point of penetration. So again, there's a whole range of normal. The definitions have to include bother, have to include something that's happening often that you have lack of control for. But again, we have patients that don't fall into any of those categories too, right? We have patients where maybe it was just a one-time event where it occurred, or it's situational, like something that's happening with a new partner that they really like or that they're really attracted to. So there's a whole range of factors that impact that and what's considered normal.
That's important to know. So you said bother a few times, and I think that's important to dive into. If somebody, whether it's lifelong or occasional or new onset, they find they ejaculate in a time span shorter than what you mentioned, whether it be the 1 minute or 3 minute, but it doesn't bother them or their partner. Is that a problem? Is that still considered a medical condition?
No. And that's a good question, because sometimes people try to treat that. And I'll give you a good example where that's going to be a big problem if you try to treat that. There may be, as people get older and as libidos change and hormones change and people enter changes of life, there may be a case where maybe sex is uncomfortable, which is never supposed to hurt. But let's say it's not as comfortable, or let's say your libido, your interest in sexual activity has declined. And now you take a couple who've had all their life had a happy sexual activity, happy sexual life, where the husband has always had premature ejaculation. Sexual activity and orgasm and ejaculation occurs within, let's say, 2 minutes after penetrative intercourse. And now you try to give him medications or treatments to prolong that. Now you completely change their dynamic. This is something that maybe the partner didn't want to last that long, or it wasn't enjoyable to them. And so again, it's so important for you to look at, number one, ask the patient what their goals are. And if it's something that's bothersome, are they bothered by it? Is their partner bothered by it? And then we can kind of focus a multifactorial way of how we can treat it and address it.
Got it. And the other question is, so you delineated two different types, lifelong versus kind of more new onset. Does that make a difference in terms of how the problems are approached?
We approach them really about the same, by getting a complete medical history, sexual history, physical exam. But oftentimes, sometimes treatment modalities may be different depending on whether it's lifelong or acquired.
Got it. So let's dive into, I know a lot of guys are interested in, okay, this is great. Maybe I fall into one category or the other, but it seems like this is me. I'm bothered by it. This is a real issue. What causes it? Especially, like, again, if you're talking about new onset or lifelong, what's causing this premature ejaculation?
Well, just like the different treatment options we have, there's many causes of premature ejaculation. They can range from psychological causes to behavioral causes, as well as biological or anatomical causes. The sexual response cycle, what we look at in men is this kind of linear process, right? That starts with sexual excitement. You have desire, you get aroused, and then you have a climax and then resolution. So normally you get two distinct events, right? The first is going to be you have an orgasm where you have this sense of intense pleasure, and then that's followed by typically the second response, which is ejaculation, or the antegrade or forward expulsion of semen from the urine channel or the urethra. And they're typically simultaneous in men that haven't had pelvic surgery or radiation, but they're actually two separate events. So when we think of just ejaculation itself, normal ejaculation relies heavily on like the function of a man's prostate and their bladder neck. It's also largely related to your central nervous system or from the brain effects. There's lots of neurotransmitters or hormones that impact the ejaculation process. So a lot of things that go in. And then, even at the end of it all, despite everything that we do know, there's still a lot that we don't know about the whole process of what causes an orgasm and what causes ejaculation in people.
So a couple of things that come up online, if you look up premature ejaculation, one thing that comes up is that if you're having premature ejaculation, it means you're not having sex frequently enough. Is there some truth to that? What is the reasoning behind that?
So the reasoning behind that is that in men, an orgasm is typically going to be experienced when you're at your peak sexual arousal, right? And so it's followed in men by a shorter refractory period during which arousal and sexual climax aren't going to be possible. And again, the refractory period varies as well for men. It can range from as short as a couple seconds to over hours. So the duration of the refractory period tends to become longer in men with increasing age, as well as with frequency of sex. So in men who've gone a long time between sexual activity, and maybe you're with a partner who you're very sexually aroused with, they may have a shorter intra-ejaculatory latency time than would they be having more frequent sexual activity or with a partner that they're comfortable with and that they've been with for a longer time period. Usually that type of frequent sexual activity or that type of what's called acquired premature ejaculation is usually not lasting, and it doesn't meet the set definitions of a true premature ejaculation, and it's referred to as more kind of a situational.
Got it. And then also the other thing that's come up is hypersensitivity of the penis. Like uncircumcised men might get it more than circumcised men because circumcision can decrease sensation. Is there truth to that as well? It's like just its penis just too sensitive?
So actually, no. And that's a good question too, because circumcision in and of itself has no impact on frequency or duration of premature ejaculation in men. Are some people reportedly more hypersensitive? Sure. But that doesn't mean that they're going to be more predisposed to having premature ejaculation.
Got it. And so if guys are at home, before they're seeing a doctor, before they seek help, are there any things they can do at home, if you will, to try to increase their time of ejaculation?
So sure. So, number one, ways to prevent it or help improve it if they have it, healthy lifestyle, right? A healthy lifestyle is important for everything from good erections to premature ejaculation. So lifestyle factors, eating a healthy diet, physical activity, not smoking. If you have high blood pressure or diabetes, taking good care of yourself and controlling those and seeing a doctor to treat those. Other things that a man can do at home. If it's been a long time before having sex, you can ejaculate or self-stimulate prior to seeing a partner. But other than that, it's really seeking out the reasons, which, you get from taking a good medical and physical and sexual history from someone and seeing a doctor to try to find the root cause of theirs specifically. For example, in a man that's undergone a recent trauma or sexual abuse, obviously that would be treated a little differently than someone that's had lifelong premature ejaculation with no history of abuse or sexual trauma.
Got it. So those kind of factors will help to delineate kind of what potential treatments are available.
Absolutely.
What other type, if a guy comes to you for consultation, says, listen, I've tried this stuff at home, I tried to increase frequency, I tried to have, to self-stimulate before, nothing's really working, it's not really changing anything. And they come to you and they say, how can you help me? What would be the expectation? That you had said you'd take a good medical history, ask them their question about other medical problem stuff. What other things would you ask or do? Are there any tests that would be done for a guy that comes in with premature ejaculation? Kind of what would they expect in seeing you for that problem?
All right. So when you see someone or a sexual health expert like myself, when they come in to see you, we're going to ask really nitty gritty questions. We're going to get down to the detail of it. We're going to get very granular. So I'll ask them, when did it occur? How long has it been going on? Is it associated with any medications or substance use like alcohol or tobacco? Is it associated with a specific partner? Or has it been going on with all of your partners? Does this occur when you're with a partner, or does it occur also when you're by yourself, self-stimulating? You want to ask, is this a bother to you? Is this a bother to your partner? Why are you seeking help about it now? Why now? Is it that it's never bothered him and now he's with a new partner and it's a bother to her? And why is it a bother to her? So there's so many different questions that you can go from there. A physical, medical, sexual health history is all that's required for a diagnosis of premature ejaculation. But we do have some validated surveys and tools like the Premature Ejaculation Diagnostic Tool and other surveys and questionnaires that can also help us kind of quantify the duration and the frequency and the bother of premature ejaculation with patients. It's a very subjective complaint, because we're usually not in the bedroom with patients. We're not saying, all right, here's a stopwatch, click, right. How long are you going, right? So really getting to know them and asking all those questions and really getting down to it will help you kind of determine what's going to be our next best steps. And then, you can kind of go over all the different options that we have available.
So, yeah, I mean, that's probably reassuring for guys to know they're not going to get poked and prodded. I mean, most guys get nervous about seeing a doctor, right? And this is kind of embarrassing on top of it. And then you're going to talk about poking and prodding. So it's a conversation, which, again, there's a certain level of embarrassment you have to get over for that, but it's well worth it to get to the other side of the problem. Now, you had said that upon having this discussion, you then present the guys with options on a broad, before we dive into individuals, on a broad scale, what is the range of options, I guess, for premature ejaculation?
So the range of options include everything from behavioral to psychological to pharmacotherapy or medications.
Mm-hmm. So let's dive into some of those. So like, again, I saw, there's a lot online about behavioral treatments, different types of therapy, psychotherapy, behavioral therapy, even physical therapy for that matter. How do those therapies work? What's the real crux of what they're trying, or I guess I know what they're trying to achieve, how they're trying to achieve it, I guess.
No, absolutely. So I'll start with psychotherapy. Actually our guidelines are the American Urological Association, which is the AUA guidelines for urologists, is that they actually recommend that we as physicians consider referring men with premature ejaculation to see a counselor or a mental health professional that has expertise in sexual health, because oftentimes they can help with things like meditation or focus control or other adrenaline or serotonin mediated responses that occur in men that can control ejaculation and or erections. So the thought is that by undergoing some therapy that we can either target the root cause of what's causing a man to have premature ejaculation and help with the relationship itself and building that intimacy. Perhaps the premature ejaculation in and of itself is not the problem, but more importantly, the man needs to spend more time with foreplay or arousal with his partner so that she can get there too. As you know, most women don't orgasm by penetration alone. Over 85% of women don't orgasm with penetration alone. So oftentimes when I have patients come see me in the office, a female partner may say, well, I just feel like a receptacle. It's just done and that's it. And so if you go through psychotherapy and you talk and finding the root cause within the interrelationship dynamic, then you can kind of figure out, okay, hey, here's maybe if I do this or I do more affection and attention with my partner, it wouldn't matter that the actual act of penetration itself and ejaculation occurs quickly, but perhaps, the foreplay and she also is satisfied. So again, the importance of doing psychotherapy. Behavioral therapies is another one. Oftentimes there's very good data that shows by combining behavioral and pharmacological approaches that's actually going to be more effective than either modality alone. But behavioral therapies can include different manual things that we do, such as what's called a start-stop technique, or basically trying to, once you feel that you're getting close to the edge, you're about to ejaculate, that you stop or you pull out, or there's a squeeze technique where you squeeze the shaft of the penis, or some people even suggest thinking of something completely non-sexual, like a crying baby, or something that absolutely would not make you think about being in the mood. Could be beneficial, but And then when we look at physical therapy, again, there's really an absence of good data that surrounds physical therapy for treatment for premature ejaculation. And that's only because most of the studies that we have don't have like standardized protocols, which means some of them looked at doing pelvic floor physical therapy for 4 weeks. Some looked at doing it for 12 weeks. Some had different number of visits with their doctor and follow-up. And so many also didn't really quantify the definition of premature ejaculation accurately or the same. So in some of these, maybe the person just had a situational premature ejaculation, right? They're with a new partner. It was a new partner after, a marriage, after a divorce. And so it would impact them significantly there. But there are some studies that show some improvement with physical therapy, but again, it's just the data. We don't have standardized protocols and we don't have the long-term outcomes to see if this would be impactful. The most common ways that we treat it and what's recommended by our guidelines or our governing board, the Urology Association, is that you're going to look at behavioral, psychotherapy, and pharmacological ways to treat it.
So I'm glad you brought up some of these points because I think it's so interesting to hear, right? If a guy has premature ejaculation and they're like, oh, this is some kind of physical problem, and if I can just last a little bit longer, all my issues will be solved. But the example that you brought, when the partner, potentially a female partner, has an 85% chance of not reach orgasm, regardless of how long his time to ejaculation takes, that's a whole different dynamic, right? And it's just kind of bringing that partner into the equation and understand that the solution may have nothing to do with the timing of your ejaculation. It may have to do with so many other things. And I think that's an important point for guys to understand, that this is not just a physical, something's wrong with your body. This is a lot more at play, and a lot of, so much of this is psychological. So, at least on a high level, what I'd love to know, and the guys would love to know, if they embark with the partner or without on this behavioral and psychological therapy road, what time span are they looking at? Like, is this kind of like you go for a treatment and you're good to go? Or is this like something that takes many weeks or months? What does that journey look like time-wise?
Good question. So no, just like exercise, you're not going to see a result the first time you hit the gym and lift those weights or run on a treadmill. It's going to take a little bit of time. And by time, I think a good investment for someone to at least anticipate in their heads is about at least 3 months of doing something before you'll notice a significant improvement. Again, we don't have great quality data that's looked at X number of time frame, but I think realistically, when we look at behavioral and physical therapy treatments for other issues like male incontinence or ejaculatory pain or things like that, I think you're looking at more of about a 3-month time frame to really see an improvement if you're going to see one.
And if in that 3-month time frame, it's all about expectations also. Guys are going to come and say, okay, I'll invest the 3 months, but so now you're saying I'll go from 3 minutes to 3 hours, right? What is a reasonable expectation? I know it will change, obviously, person to person and what the cause is, et cetera. But on a general level, what type of expectation would you frame for guys going into this type of journey with behavioral therapy? Mm-hmm.
So good question. A lot of times what you're going to see really is not, you're not going to go from 30 seconds to all of a sudden an hour or 30 minutes. Most of the time, the data that we have seen that we've looked at will show anywhere from a 3-fold to a 5-fold increase. So that means if someone's at 30 seconds, and they have an improvement, maybe up to 2.5 minutes. Okay. I think some of the better data comes when we use pharmacotherapy with that, but even then you're looking at maybe someone that's 1 minute, taking them up to maybe 5 or 6 minutes at best.
Got it. Well, that's good to know. At least they know what they're getting into for sure. You mentioned pharmacotherapy, medications, right? Everyone loves the idea, I'm just going to take a pill and get better, right? What is involved with medication and how does that work?
So good question. So we actually have numerous pharmacological or medical treatments that we can do that can be utilized for the management of premature ejaculation in men. And these, not everything comes without risk. And so again, you need to talk this over with the patient and his partner about what are the risks of medication versus the benefits of how long it will actually improve or give it. Many of these medications are lifelong medications, meaning if you stop taking it, you won't have the same effect anymore. You'll go back to where you were, your premature ejaculation or your intra-ejaculatory latency time. So again, a good discussion of the risks and benefits of the medications, how to take them, how long to take them needs to be had before you start doing this. But in general, we have medications that can include what's called SSRIs, or selective serotonin reuptake inhibitors. These are often medications that are prescribed traditionally for anxiety or depression, but we use them, off-label to treat premature ejaculation because they have a side effect that can cause delayed orgasm or delayed ejaculation in men. We also have medications called tricyclic antidepressants, or TCAs, which again have a similar side effect profile of your SSRIs. There's topical or local anesthetics that we can put on the penis, the glands. There's also a medication that's typically an opiate called tramadol, which can be used for on-demand premature ejaculation with partners, as well as alpha adrenergic blockers. Many of these medications can be utilized alone, or even better with behavioral modifications or psychotherapy in combination.
So let's break those up into some. So like a couple you mentioned were kind of more, I guess, psychiatric or psychological type medications, like the SSRIs and the antidepressants. I guess the question is, obviously, we talked about how a big part of treatment and psychotherapy, it takes the psychological element. I mean, I know you mentioned that for these type of medications, it's a side effect, but do you think it might be treating an underlying kind of psychological issue that's contributing to the premature ejaculation, or it's just kind of more unrelated and it's just a side effect of it? It's kind of a difficult question to answer there.
So if I hear you right, you're asking, is the medication in and of itself treating more of a psychological issue, or is it something, just a side effect that's occurring?
Yeah. So like, for instance, like, is it, the SSRIs are used to treat depression and anxiety. Is the thought that these guys have some underlying depression, anxiety that's causing the premature ejaculation, or it's kind of just like you said, it just happens to be a nice side effect of the medicine?
So good question. I think it's both. I think in some men, certainly the anxiety or depression is a root cause of causing this, as well as with their sexual relationship, what the dynamics are of that. But there's actually, we have good data that shows that in men, ejaculation in and of itself is largely controlled by some neurotransmitters or hormones in the body that in the brain, like dopamine or oxytocin, whereas the inability to ejaculate is controlled by a neurotransmitter called serotonin or GABAergic receptors. And so when you take these SSRIs, or selective serotonin reuptake inhibitors, it's basically modulating those receptors in your brain so that you can't break down the serotonin and can't modulate it. So as a result, it has a side effect of causing delayed orgasm or delayed ejaculation, which for many men, sometimes they come to see me and that's their complaint, right? They've just been put on a medication for anxiety and they're upset that it's taking so long. But in men that have premature ejaculation, this is actually a wonderful side effect of the medication because it can help them.
And is this medication expected to be taken on an as-needed basis, meaning an hour, like kind of like the Viagras of the world, or is this something that somebody would have to be on indefinitely, like a cholesterol medicine, to maintain that effect?
No, good question. So specific SSRIs, or those selective serotonin reuptake inhibitors, like paroxetine, sertraline, fluoxetine, or citalopram, and like the tricyclic antidepressant, clomipramine, most commonly, those are all medications that need to be taken every day. And the reason for that is that they're receptor modulators. So they have to build up in the body, which usually takes about 2 weeks for you to see the maximum impact. And then once it's built up, you got to keep taking it to see that impact. If you stop taking it, usually within a week, all of the effects come out and then you're not going to have that same impact anymore. Whereas there is a medication, it is called Dipoxitine. It is not available in the United States, but it is treated in Europe. And it is actually it's different because it's a rapid acting, short half-life SSRI, which is actually supported as a role for an on-demand treatment for premature ejaculation. But that's the only SSRI that's an on-demand that you would take usually about 1 to 2 hours before intercourse. But as far as all the other SSRIs or your tricyclic antidepressants, those must be taken daily to see the impact. And it takes about 2 weeks. You know, the dosing is variable. But one of the important things to know about anyone on an SSRI is that it should be avoided in men that have a history of bipolar depression due to a risk of mania. And there should be some caution, you know, that's been suggested in prescribing it to adolescents or men that also have maybe comorbid depressive disorders, because there's been some slight association with suicidal or increased suicidal ideation in these patients. The other important thing to note about these SSRIs is, again, important to talk about the risks of any treatment, is that patients should be advised that if you've been on it for a while and let's say all of a sudden you and your partner break up, and so you're not planning on being sexually active for a while, you know, you really shouldn't stop the medication suddenly or do a rapid dose reduction if you're on a daily dose, because it can precipitate something called SSRI withdrawal syndrome. And so again, the medication can be great for a lot of patients and a lot of couples, but you just want to make sure that you talk about all the risks with it.
And that's really good to know. And like with other medicines that you're taking for a long time, like cholesterol or blood pressure or whatnot, there's often some little, maybe not risk, but maybe side effects of it. What are like kind of the main side effects to expect when taking this type of medicine?
SSRIs, they can lead to, sometimes people have what's called kind of a foggy feeling at first. For the first 2 weeks, they feel a little cloudy, a little foggy. Some patients, you know, can have allergic reactions to these as well. They can have sweating. But most of the time, if you start them at a low dose and if needed, slowly titrate up, most people tolerate this well, assuming this is their own SSRI. They're not on other SSRIs for things. And if they are, which, you know, when we see patients like this, we oftentimes have patients that come in and they're on multiple medications. A good rule of thumb, I think, is to always talk to their psychiatrist or whoever's prescribing those medications to see if it's even safe to add something else on top of what they're on.
Got it. And so I mentioned a while ago, just in comparison, about Viagra or PDE5 inhibitors. There's a lot out there in the cyber world about how, you know, just take Viagra and it's going to solve your premature ejaculation problem as well. What are your thoughts on that?
So in those men, I would argue that it's actually the erectile dysfunction that is actually causing their premature ejaculation. Okay, because what ends up happening in a lot of these men that maybe have underlying, you know, erectile dysfunction is that the ED occurred first. And so what happened was either, you know, because of their secondary premature ejaculation that occurred as a result of having erectile dysfunction, they either had a need for more intense stimulation to attain and maintain an erection, or due to maybe the anxiety that they had associated with worrying about difficulty in attaining or maintaining an erection, that all of a sudden they've kind of created this premature ejaculation. So in those patients, absolutely treat them with a PDE5 inhibitor or a phosphodiesterase 5 inhibitor. That's what you said, Viagra, sildenafil, Cialis, tadalafil, all the common names you may hear. And then by treating the erectile dysfunction, the PE will resolve in and of itself.
Versus somebody who has totally normal erections, where that's not really going to be adding much to the premature
if they have normal erections, a PDE5 inhibitor is not going to have an impact on lifelong or acquired premature ejaculation.
Got it.
But again, there's a large majority of men who come that we see in our office that they're referred to me because, you know, they've seen a doctor and they're like, premature ejaculation, I don't know how to deal with this. Send them, you know, to Dr. Bernie. And upon further questioning, which is again why it's so important to get that full medical, sexual, social history, you find out that which happened first. Actually, it's not the premature ejaculation. It's that they started to develop erectile dysfunction, where all of a sudden they were in a new relationship and had erectile dysfunction on the first, you know, activity. And then all of a sudden it led to this perpetual kind of catch-22 of now every time they were in a new sexual encounter, adrenaline secreted. Well, adrenaline is our most potent vasoconstrictor known to man, right? So back in caveman days, when we're running away from a caveman or lion and tiger chasing, right? We don't want to have blood in the penis. We don't want to have an erection. But what we do is we vasoconstrict and blood goes out of the penis. And so as a result, that adrenaline mediated response, you get in a sexual situation, anxiety, nerves happens, adrenaline gets secreted, and then you lose your erection. And then it just perpetuates because you think about it again the next time you're in a sexual encounter, and it just occurs over and over. Thus the term where people will say psychological erectile dysfunction, but I kind of prefer the adrenaline.
Another type of medication that you mentioned, aside from the oral, was topical medication. How does that work? What is the mechanism, and how do guys use something like that?
Okay, very good. So the use of topical or local anesthetics, such as things you may hear like lidocaine or prilocaine or benzocaine, or by a brand name, maybe Promescent, alone or in association with other things, is used to diminish the sensitivity of the glans penis. And it's actually one of the oldest known pharmacological treatments that we have for premature ejaculation. Typically, these medications, are often considered with first line, like SSRIs are considered first line therapy and can be given in conjunction with topical anesthetics like Promescent. But if someone wanted to try it by themselves or in combination, typically best results are seen when they're in combo, but they can be applied as either a gel or an ointment or even topical wipes or even just a spray. Some of the spray forms are actually mixtures of like a lidocaine and a prilocaine together. But the thought is that it penetrates the epithelium of the glands of the penis. It doesn't necessarily penetrate as much into the skin of the shaft, but it's applied on the penis and usually the glands. And at least 5 minutes before sexual activity. Some different brands may recommend 10 to 15 minutes prior to sexual activity. And then you want to make sure you wipe it off, because if you forget that important step, then you might be leaving your partner with some numbness and decreased sensation as well. No. Which we don't want to do.
Good point.
But it works well in some patients. Again, we tend to see better results when it's used in combination with SSRIs or behavioral therapies. But as you may guess, the side effects are going to be numbness or decreased sensation, especially if it's not wiped off appropriately, which can translate those side effects onto your partner.
And those topicals are also based on prescription. You can't just pick them up at the pharmacy, I'm assuming, or can you?
Most of the time you can do them as a prescription, but like we have so many sites now like Roman or Hims, where men can also, or even go online to Promescent and get the topical treatments as well. And, again, when you were kind of asking, what are the results of these? Well, we've looked at studies that looked at mixtures that were applied to the penis, about 5 minutes before. And some of these studies have actually shown about a 6-fold increase in the IELT, or that intra-ejaculatory latency time, which is the point of vaginal penetration to ejaculation.
And is that the same? So I forgot to ask you that about the medication, the pills, like the SSRIs and the Tricyclic, the same thing, about 6-time improvement, or is that different? Sorry, you probably didn't hear me there. With the medication, the pills, is that the same type of efficacy as well?
So SSRIs, actually data shows that those when taken daily can improve about 65 to 70% of men will see an improvement using SSRIs. Again, it takes it anywhere, based on looking at which studies, anywhere from 3 to 6 times.
Got it. So pretty effective for sure. Now, jumping out of kind of medications and pharmaceuticals, one thing we didn't talk about, and I don't know how big a role it plays, but there's also online, there's thoughts about procedures that are described for it. Things like hyaluronic acid injections or dorsal nerectomies, which again, few have heard about, but is there a there? Are those actually effective, or is this kind of more experimental stuff?
So good question. So I have to preface it by saying that our AUA, or our American Urological Association board, states that there is insufficient evidence to support the use of these alternative therapies in treatment for premature ejaculation, and that surgical management, which can include anything from injection of bulking agents to the neurectomies that you've talked about, should be considered experimental and should only be used in the context of an ethical board approved clinical trial. Okay. But so we can at least educate, right? Because if we don't talk about it on here, people are going to find things online. And as you know, there's good and bad information in the World Wide Web. But the thought behind, let's say, the hyaluronic acid injections is that you're basically, the main limitation we have for medical treatment for premature ejaculation is that, you get recurrence of premature ejaculation after you withdraw the medication. So they looked at doing the effects of doing glans penis augmentation by injecting this hyaluronic acid gel for the treatment. The thought is that you inject it into the glands of the penis, and it's going to block the accessibility of these tactile stimuli to nerve receptors. It's going to block the ability of tactile stimulus impacting your nerve receptors there. Typically, I think the units are about 2 cc's of hyaluronic acid that's injected into the glands. And when I've looked at studies on this, it showed an improvement of about anywhere from maybe if someone's initial was 1.5 minutes to 4.5 minutes of an IELT. With data in some of these very limited studies that did not have long-term data. And again, the quality of the studies is very touch and go. It showed that about 62% of partners were satisfied and about 75% of patients. But again, data is limited and there's no long-term safety or efficacy data. So again, these are not recommended, but the thought is you're going to inject an agent to basically dull the sensation. When you look at a dorsal nerectomy, what does that mean? It means we're basically going to resect the dorsal nerves, or the nerves that control sensation in your penis. So again, guidelines don't recommend this, but what's happened is the use of a selective dorsal nerectomy has actually increased for many years in the Asian countries. And this is where we see most of the data that we have on this. And the way that this works is that when they looked at these cadavers and looked at patients, they found that, and in live patients during surgeries, they found that men with premature ejaculation had greater numbers of dorsal nerve branches. Both the size of the nerve branches were wider and they had more branches than guys that did not have premature ejaculation. And so the thought was, well, maybe we can resect some of these extra branches, and that way it'll kind of dull sensation and it can improve lifelong premature ejaculation in men. And again, their data, which is, again, quality is questionable. There's nothing standardized and there's smaller studies, showed that you might see up to a 5 times improvement in the IELT, or that intra-ejaculatory latency time, and patient satisfaction. But again, are they durable? Is it going to last? There's really an absence of data on that. And then more seriously is that, what are the risks related with this? Well, when you're cutting penile nerves, you risk permanent numbness in the glands, permanent decreased sensation in your penis, which is awful. Like, great, we cured your premature ejaculation and now you can't feel anything, as well as wound infections, hematomas. So again, not recommended by our current guidelines, but it is a treatment option to at least know what it is and where the thought process behind it comes from.
No, that's actually very helpful. As you said, it's better to hear from you than just to kind of look it up randomly on Google, for sure. And this was very helpful. Last question in terms of treatments. One thing that I've also come across, which is kind of alternative treatment, acupuncture. Have you heard about this as an option? Is this something that you use?
So very good question. So normally I am, all about alternative and holistic treatments, because again, there's so much that we know, and we know like acupuncture works great in women with infertility, and it's been around for years and years and years and years and years. However, the same thing kind of when we're looking at acupuncture is that there's just not a lot of great quality data. It's not long-term data out there to really tell us, how it's going to work. But there is some studies that looked at doing acupuncture. There was actually 2 randomized controlled trials that are out there that looked at acupuncture for premature ejaculation. And only one of them actually showed a slightly increased intra-ejaculatory latency time period over placebo. And that was just by about 1 minute. So takes you from 30 seconds to 1.5 minutes, for example. But, there is some preliminary evidence that there is some effectiveness of acupuncture, or even some of the Chinese herbal medications. But again, the data is kind of unclear quality. And if we had some more well-conducted randomized controlled trials, I think it would be really interesting to look into this, because we certainly know there are benefits of acupuncture and other medical things, other conditions.
For sure. Now, last question about treatment. So you had said that sometimes there's a possibility of doing combination treatments. First question with regards to that is is it even more? So again, if it's 6x for one and 6x for another, is it like 12x if you do both, let's say, medication and therapy, or how does that work? Additionally, how does that summation work there, or does it?
No, I wish, right? Because then I just pile on every one of the medications. Right. Now we got 30% improvement. 30 times, but no, even in a lot of the studies where we look at combination data, which is where you're going to see the best effects, like combo, looking at behavioral and SSRIs or pharmacological, as well as, psychological and pharmacological. Still, you're looking at usually the average is about a 6-fold improvement.
Basically, I was saying that it's based on what you're saying was that it's not a question of adding all these treatments together. It's just a question of tailoring the treatment to the problem. So I guess if you're seeing somebody with a lot of psychological potential causes, you might go more psychotherapy versus others where you may try more medication. Is that correct?
Absolutely. Especially if during your exam, you find out this is a patient who's newly widowed, they're in their first new relationship, they've never had premature ejaculation before, I tend to err on the side of least invasive over dumping the whole barrel of every medication at them. That said, that's not to minimize the significant distress that this can cause a lot of men. And knowing that psychotherapy and pharmacotherapy, these things take time, behavioral and psychotherapy can take time. So I think it's just a discussion of the risks and the benefits of it. Because you want them to feel better. You want them to be able to have confidence and feel good about themselves and restore that masculinity that may be gone from having this problem. And so again, kind of a discussion of risk benefit, but again, it's so important to have that full medical and personal history so that you can kind of understand what's maybe the root cause and what's going to help best. But in the meantime, maybe giving them something to get them over that hump.
Like with so many problems, it's not always the same hammer for the nail. Basically, lots of ways to treat the problem. Dr. Bernie, thank you so much for your time and your insights. This has been fantastic. I know the guys would appreciate it tremendously. Before we let you go, we'll ask you a question completely unrelated to premature ejaculation. This podcast is called Better Man Clinics, and the idea here is getting better, right? Living your best life. And as a successful person, what is the secret to your success? How do you live your best life?
I think living your best life is valuing yourself and knowing that you're worth it. Right? Like take care of your body because you only get one of them. You only get one chance of it. If you can't get yourself motivated to quit smoking or to exercise or sleep better or eat healthy, then do it because of your partner or do it because your kids need you around long. But value yourself, especially in a society where we all too often put our kids at front of us or our friends at front of us or family members before us. It's so important to man up, take control of you and take care of you and prioritize you, because when you take care of you, you can be better to help take care of others.
Great advice. Dr. Bernie, thank you so much for your time and your insights. And for all of you guys watching and listening, thank you for joining us. And remember our mantra here at Better Man Clinics, your best life is a journey and not a destination, and use every single day to get just a little bit better. We'll see you all next time.